Then we'll move on to the benign prostatic hyperplasia. So benign prostatic hyperplasia, we all know about it, but the term has been now changed to nodular hyperplasia of the prostate. Okay. So anyways, hyperplasia is a kind of cellular adaptation, right? So any cellular adaptation is a reversible change and it's a benign change. So no point in having both benign and hyperplasia in the name. So they had changed it into nodular hyperplasia of prostate. And it is not a pre-malignant condition. So remember, it is not a pre-malignant condition. And the origin of this benign prostatic hyperplasia in the prostate is going to be from the transition zone. So transition zone is the zone which is present around the prostatic urethra. So in the prostatic urethra is going to be compressed because of this nodular hyperplasia. So what will happen? The patient will come with urinary complaints. So they'll have frequent urination and then they'll have incomplete micturition also. So urinary complaints will be there, nocturia will be there in these patients, and then dribbling of urine. And other than that, what is the pathogenesis involved in BPH or nodular hyperplasia? So normally the testosterone hormone is going to be converted into dihydrotestosterone by the enzyme called as 5-alpha reductase. So this dihydrotestosterone is the actual thing which is going to cause the nodular hyperplasia. So in nodular hyperplasia, you are going to have a hyperplasia of both the epithelial and the stromal component. So in a prostate, normally you are going to have the benign glands surrounded by the basal layer, and then you are going to have a fibromuscular stroma. Okay, so both the components will be undergoing hyperplasia in a nodular hyperplasia of the prostate. And which is the one which is responsible for this? It is going to be dihydrotestosterone and not testosterone. Remember, this is a very important MCQ again. So dihydrotestosterone is the one which is responsible for nodular hyperplasia. So how do you treat these patients? So you will have to stop the production of this dihydrotestosterone. So the 5-alpha reductase, if you block this enzyme, you can prevent the formation of dihydrotestosterone. So pharmacologically, you can use the drug finasteride, which is going to block this 5-alpha reductase, thus relieving the patients of the urinary complaints in BPH. So next we'll see about prostatic cancer. So the usual risk factors associated with prostatic cancers is it is going to present in quite elderly people, so more than 50 to 60 years, and increased fat diet is going to be associated with a risk. And then lycopenes, which are present in fruits and tomatoes, it's going to be protective for prostatic cancer. So the genetics of prostatic cancer is very important. So you'll have to mark this up only. So BRCA2 mutations. So BRCA2, which was a DNA repair enzyme, right? So BRCA2 gene, we already saw it is going to cause hereditary breast and ovarian cancers. And especially BRCA2 is associated with male breast cancer. Apart from that, you are also going to have prostatic cancer. It is going to be BRCA2, which is associated with the prostatic cancer. Other than that, we are having TMPRSS2 rearrangements, which is associated with Ewing's family of transcription factors. And then hypermethylation of glutathione S transferase. Then reduced or downregulation of E-cadherin. Okay, so all four of this is going to be associated with prostatic cancer. Then the precursor lesion for a prostatic cancer is again an intraepithelial neoplasia called as prostatic intraepithelial neoplasia, which is given the term PIN. Okay, so the prostatic intraepithelial neoplasia and the prostate cancer is going to arise from the peripheral zone. So nodular hyperplasia of the prostate was arising from the transitional zone, while prostatic cancer is arising from the peripheral zone, outermost zone. So how will the microscopy appear like? So I already mentioned the glands of the prostates is going to have two layers. So this kind of cuboidal layer surrounded by the basal layer. So here the basal layer is going to be lost in prostatic cancer, and after which these glands are going to invade. So the tumor cells forming these glands are going to invade into the stroma. Other than that, where there is an important feature which you'll have to document in prostatic cancer, which is perineural invasion. There are very few tumors which have a high propensity for this perineural invasion. So out of that, prostatic cancer also is very important. So let me tell what are the tumors which have a perineural invasion usually. Prostatic cancer, then we have pancreatic cancers, then cholangiocarcinomas, then adenoid cystic carcinoma. So adenoid cystic carcinoma, you must have all read it in salivary gland tumors, right? So adenoid cystic carcinoma. So all of these are known for having a perineural invasion. In order to grade this prostate cancer, so you'll have to use a system called as Gleason's scoring and grading. So based on the pattern of arrangement of these tumor cells, we are going to give a score based on this Gleason scoring system, and then we'll assign a Gleason grade also. So based on the Gleason's grade only, the patient's prognosis and treatment will lie upon. Okay. Immunohistochemically, the prostatic cancers are going to be positive for PSA, which is prostate specific antigen, and other than that, AMACR positive. So it is a racemase enzyme. So AMACR positivity will also be present in prostate. You can also measure for acid phosphatase enzyme as a biomarker in the serum. AMACR, if you remember, it was also positive in the papillary renal cell carcinoma. Remember? So papillary RCC and in prostatic cancer, you have AMACR positivity. So prostatic cancer usually metastasizes to the bone, and it usually presents late. Since it's a peripheral, it is arising from the peripheral zone. So the time by which it presents will be late. So the patient presents at a later stage. So bone, it usually has a osteoblastic metastasis. Okay, many tumors we must have seen bone metastasis, but most of them are osteolytic metastasis. But prostatic cancer causes osteoblastic metastasis. How does it reach the bone? It reaches through the Bateson's plexus. So Bateson's plexus is going to be a paravertebral venous plexus. So through that, it is going to reach the lumbar vertebra, and it's going to cause low backache. So the classical symptom the patient comes up for a prostatic cancer presentation itself is during metastasis, and they complain of low backache. So if you probe the history, they'll be giving this low backache. So whenever there is an elderly male coming with chronic low backache, then you'll have to definitely suspect a prostatic carcinoma and do a per rectal examination. So on per rectal examination, you can feel the mass in the prostate. Okay. Then how do you diagnose this prostatic cancer? You'll have to check for the serum PSA levels. So serum prostatic specific antigen levels are going to be elevated. So there is an age related cutoff for all of this. So normal levels will be less than 4 nanogram per ml. So if it is raising above more than 4 nanogram per ml, you'll have to suspect prostatic cancer. So they are depending upon the age. So next you will check for the prostatic specific PSA density. So density, it will be based on the volume of the prostate based on the ultrasound measurement. Other than that, you will have to correlate with the PSA levels also. So both of this will give the PSA density. Then the PSA velocity. So the rate at which this PSA is increasing. So if it is more than 0.75 nanogram per ml per year rise, so in a year, if there is going to be more than 0.75 nanogram per ml rise, then it is suspicious for prostatic cancer.